Welcome to the CodeCast Podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast Podcast. My name is Terry Fletcher. Today is the 207th episode of the CodeCast Podcast, and today our topic is ICD-10-CM coding update. It is October 5th, so you know that on October 1st, the fiscal year for the ICD-10 or diagnosis codes, they became into effect. So now they are active, and we want to make sure that we understand what's going on with that. Now, we did have a reprieve for 2022 because remember in 2021, we had 485 codes added. So that's definitely less this year, probably because of the mid-year additions because of COVID, but also it is clear that they're trying to give us a little bit of a reprieve since we've had to deal with the COVID pandemic. And so it's not going to be as tedious as it usually is when it comes to adding our codes and being updated. So what I'm going to do is I'm going to give you the top 8. So it'll be kind of it's a version of the top 10 Tuesday, but it's a top 8 and just really looking at kind of an overview. I do have an on-demand and also a recorded live webinar on the ICD-10-CM update. And so feel free to email me at terryfletchercpc@aol.com or terryfletcherccc@gmail.com if you would like to get a recording of that. And yes, we do charge for that because it comes with CEUs and a PowerPoint. Okay, so let's see. What are the top 8 as far as the key things to know for the 2022 ICD-10-CM coding? So first of all, we have 159 additions, 20 deletions, and 37 revisions for a total for 2022 of 95,524 codes. Now, just to be clear, additions can mean two things. Either it's a brand new code for that fiscal year, or it is a code that used to have maybe 3, 4, 5, 6 digits and now has had a digit added for more clarity or more specificity of the code. So it has an extra character. Deletions mean they've retired the code, or it means that it's no longer a valid code. So be aware of that. Do not delete those codes though, just kind of retire them in your system, put do not use, because it could be tied to a previous claim. And if that claim isn't paid yet, then it would be suppressed in your system. So try not to delete anything out of your system. Anything that's revised, doesn't have to do with coding as it has to do with the language of the code. So that means that the coding language, maybe they added something that says with kidney disease or involving this disease or excludes this. So it's more of a language revision. It can also be a semicolon or a colon, or it can say with, because we know we do have some general guidelines that use that with to make a link to a lot of different ICD-10 codes. So we just want to make sure we keep that in mind as we're looking at the update. Number 2 is codes to further describe homelessness. So they did expand the code set in the social determinants of health to specify homelessness as unspecified, sheltered, or unsheltered. So that was very helpful for this year, just to give us a little bit more information, especially during a pandemic. Number 3 is codes for COVID-19. So this year, several codes were added to help providers indicate COVID-19 related conditions, treatment, and testing. They also have a new code, the U09.9, which is a post-COVID, see what I did there? Post-COVID condition, unspecified. They also have the J12.82, pneumonia due to coronavirus disease. 2019, M35.81, multi-system inflammatory syndrome, and they have added the acronym MIS, M35.89, and then other specified system involvement of connected tissue. Z11.52, and that's encounter for screening of COVID. I'm actually surprised they added that because technically that's not supposed to be added until the pandemic ends. And we're actually, in my opinion, in an endemic. We're going to have to learn to live with this in some level, and it's not going to completely be over because of all the different variants and things that it changes into, just like the flu, where eventually you just have to keep updating your vaccine for that. Z20.822 contact and with and suspected exposure to COVID-19, and then Z86.16 personal history of COVID-19. So they have not only the post-COVID condition, means the long haulers is really what that is. You still have something going on with you that's related to a COVID infection, versus personal history of COVID where you're completely resolved, completely done with it, but it is something that could possibly manifest something else in the future, but at least that your provider knows about it. So that's number 3. So make sure you are taking a look at those. Expansion of codes for describing a cough. Boy, finally. Coughs were always just basically you bill an RO5 for a cough. And that was a little bit annoying because we always had something different on that. So when you look at the cough new codes, we, instead of RO5, the 3-digit code, it's now been expanded in that section. Acute cough, RO5.1, subacute cough, RO5.2, and then under chronic cough, RO5.3, we also have persistent cough, refractory cough, and unexplained cough. And then you have cough syncope, RO5.4. Other specified cough is RO5.8, and then RO5.9 cough unspecified. So other specified meaning the doctor said they know what it is, but it's not defined, and then unspecified meaning they don't know what it is. But that's really helpful because some patients have different symptoms related to a cough, and now your physicians will actually be able to be more specific on that realm. Okay, so let's take a look then at number 5, coding for injuries, poisonings, and other certain consequences of external causes. We have 45 new codes for injuries, poisoning, and consequences of external causes, probably the biggest expansion of codes this year. So 39 codes were added to describe adverse effects, underdosing, and poisonings related to cannabis and synthetic cannabinoids, according to the Journal of American Health Information Management Association. So this was a really good ad because of how many states now have legalized marijuana and cannabis, but they have synthetic or versions of it like the candies and the edibles that are leading people from overdosing, leading them into the ER. So know that is there as well. Number 6, codes for musculoskeletal system and connective tissue diseases in Chapter 13. 25 new codes for Ortho, and basically they're looking at musculoskeletal system and connective tissues. And also there are 9 codes included in that cover non-radiographic axial spondyloarthritis by sight. Now we had some guidance for changes on laterality, and also it's interesting because we had a lot of guidance that involved coding. And what I mean by that is I should say involved coders. And so I really like that, is that they involved in the importance of coders when it comes to capturing and securing information. So the addition of guidance allowing the assignment of laterality based also on documentation from other clinicians. So what it says when laterality is not documented by the patient's provider, code assignment for the affected side may be based on medical record documentation from other clinicians. Now remember, it's not other coders, not other billers, not other front office people. It has to be a clinician. And it says if there is a conflicting medical record documentation regarding the affected side, then you still need to query your physician for clarification. Codes for unspecified should rarely be used, such as when the documentation in the record is insufficient to determine the affected side and it's not possible to obtain clarification. So they're just saying if you can't access a physician or get a clarification there, then you just want to make sure that you're clear. Also, I wanted to expand on the other patients, other than the patient's provider. So when it says other clinicians, they're saying other clinicians means that is a clinical staff member who isn't the patient's provider, but they're legally accountable for establishing the patient's diagnosis. So this can be an internal hospital nurse. This can be somebody that works with the physician and has seen the patient before. And so just make sure that you keep it clinical, or that gets a little bit messy. Number 8 is guidance changes for codes relating to factors influencing health status and contact with health services. Again, now we're dealing back with the social determinants of health. And so the reason for the encounter, for example, screening or counseling, should be sequenced first, and then the appropriate personal and or family history code should be assigned as additional diagnoses. And they gave us a lot of information that was something that we already knew, but it was just helpful to have that information a little bit more clarified in the record. So I really liked the fact that they brought that to our to our attention, I should say. The other thing, and this is something that if for those of you that are trying to explain to your provider, and this is the last thing I'll comment on, the importance of the collaborative effort between a coder and a provider. In Section 18 under the general guidelines, they updated a statement, which I cannot tell you is going to be very helpful in your role as a coder, especially from a career perspective. So it's under the General Coding Guidelines, Section 18. And it says, under Guideline 18, a statement of collaboration between the healthcare provider and the medical coder has been established in order to maintain the integrity of the medical record. So that you that are, CDI experts out there, this is going to be something for you. And I'll quote, it says, as stated in the introductory section of these official guidelines, coding guidelines, a joint effort between the healthcare provider and the coder is essential to achieve complete and accurate documentation, code assignment, and reporting of diagnoses and procedures. The importance of consistent, complete documentation in the medical record cannot be overemphasized. Without such documentation, accurate coding cannot be achieved. The entire record should be reviewed to determine the specific reason for the encounter and the conditions treated. I go along and say this quite a bit because especially those of you that may not be clinical, but you're a coder and trying to get the physician to document as much as possible so that you can look at the entire record and make good coding choices. But I really like the fact that now it's actually stated in the book that this is something that has to be done for accurate coding to go forward. It has to be a collaborative effort between the physician and the coder. And it's weird because we always knew that, but it was never really documented in black and white and what we call now white paper since everything's digital. But now we have it. So that's something you can bring to your physician's attention. The CodeCast is also brought to you today by Medisoft, a cloud-based medical billing system, a fast and highly scalable platform that transforms the way healthcare providers manage revenue cycle management. To try Medisoft, call Microwise at 800-955-0321 or visit medisoft247.com. Okay, so let's talk about our coding question today. And this one is a doozy, or I should say a good one. I got a coding question from a client that basically said, Terry, we have patients that the doctor wants to see and bill for an office visit when they are doing a COVID vaccine and the patient is in their car, so it's a drive-by. Can we also bill for an office visit and use place of service 11? The doctor can bring out a stethoscope and listen to their lungs. The answer is no, people. We've been approved for drive-by testing and drive-by vaccines, but we have not been approved for drive-by visits unless, and this was last year, unless it's for a patient who is exposed to COVID, they're doing testing, and they need to have a conversation that talks about exposure and quarantining and social distancing. And again, it's all about COVID. And so if that's not what it is, and the testing part, if to bill for, that's just a nurse visit, then please do not bill for parking lot visits. Somebody said, well, the patient said because it's open air, that's better. No, then you go to telehealth. Then you schedule an appointment, you go to telehealth, and under the public health emergency, they're still allowing the audio and video visits. Be aware that we have probably 75% of commercial plans have stopped paying for the audio only. So just be aware that that's no longer an option in a lot of commercial plans. Look on their website. But no, there's no such thing as a drive-by visit with place of service 11. So that's a really dangerous thing to start doing. Also, in the same context, I wanted to just bring something to your attention. I had some practices that are saying, we're billing telehealth now just because the patient would rather have it. And I'm like, does it have anything to do with COVID and the fact that they're trying to slow the spread? Or, is your patient unvaccinated? So you're trying to make sure that your exposure is minimized and your staff, or what's the case there? And they're like, no, it has nothing to do with that. Patient just doesn't want to sit in our parking lot, doesn't want to sit in the office. I'm like, okay, if this is Medicare, you're going to have a problem. Remember, with Medicare says the reason that they gave us the flexibilities is to slow the spread of COVID or to minimize the exposure to not only practices, but to patients who are otherwise compromised. And so with their morbidity and mortality and with their secondary problems. If it's just for convenience, those are not allowed. Also, calling patients and giving them their test results that are normal, please don't bill for a telehealth visit on that. You never billed for it before. So now to say you can bill for it now just because there's kind of an under the carpet or back pocket option that nobody will find out, please don't do that. You're going to get yourself in trouble. I'm doing so many audits on Part B services. Now, some patients have the option for telehealth under a commercial plan because they had it prior to the pandemic? Absolutely. I have Anthem Blue Cross Blue Shield myself, and we have it. They call it VIP services. I don't have a copay, don't have a deductible. They actually even encourage it, but there's a frequency guideline. You can only have 3 of these VIP visits a year through telemedicine, and it has to have an audio and video connection. So do your due diligence. Make sure you find out if that patient's contract allows it, and if it's okay during the pandemic or before that. And does it have to have either a COVID-related reason or just to slow or stop the spread? So that's really important as we move forward. Remember, we've got 60% of the population vaccinated, just about. And so, and we have at least 72% that's had at least one injection. So we have to be cognitive of the fact that we're not going to get all the flexibilities again. So it's not going to be as relaxed. And even though we know that the public health emergency probably will extend to the end of 2021, we have to just be careful that we're not overreaching on some of those services. Okay, so my personal tidbit to today, well, you probably saw my Pittsburgh Steelers are tanking right now. We're 1-2. Last 2 weeks, it's been terrible. We play Green Bay this weekend. But you know what's really nice is the fact that it's something different. And I want to just put that out there. It's not work. It's something that you can give yourself a mind vacation. Obviously, I podcast on it too because I need an intervention on podcasting. I just love it so much. But try to get yourself to do something that doesn't have to do with work. I've mentioned this before, at least once a week. You need that recuperative effort. You need that mind vacation. You need to just reset. Otherwise, you're going to get burnout. And we're seeing that a lot, not only with physicians, but with staff as well. So try to do something, read a book, do something that is not work related, at least for an hour a week. And I'm not talking about social media. Social media can be very tiresome and frustrating, as you know, because of all the political nonsense that's out there. And you can't open up your social media anymore without talking about COVID. We see it enough in our jobs, and I know a lot of us have COVID fatigue. So try to do something that won't even expose you to that. Go for a walk, go outside, just sit in your patio or your backyard or your front yard and just, have a lemonade, have an iced tea, have a beer, whatever floats your boat, but do something that's not work related if you can. And DM me, let me know what you did, and I'll shout you out on the podcast. And so everyone, just make it a great week and a great day. And thank you for listening to the CodeCast Podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.